Stripping away the biology of bone and muscle exposes the human pelvis for what it mechanically is, a dense, overlapping series of fluid networks. Intervening in this region bypasses the scalpel entirely, managing complex pathology by identifying and manipulating specific points of flow and obstruction. This diagram shows the three targeted systems: the high-pressure arterial tree in red, the delicate reproductive lumens in white, and the broad, low-pressure venous drainage system in blue. Interventional radiology manipulates these networks using an inverse mechanical logic. Operators must selectively occlude pathological blood flow to destroy disease, while simultaneously identifying and clearing physiological pathways to restore function. Mastering the fluid dynamics inside these three parallel systems allows physicians to replace invasive, high-risk surgical excisions with targeted microscopic interventions. The high-pressure arterial network presents our first major target, uterine fibroids. These are hormonal-responsive tumors that hijack the body's natural estrogen supply to rapidly construct massive parasitic build networks. We cut off those supply lines using uterine artery embolization. Uterine artery embolization, or UAE, is an endovascular procedure that intentionally clogs the arteries feeding the uterus to infarct or starve the targeted tumor. This simulated MRI matrix uses T2 weighting to evaluate tissue water content, determining if starvation is possible. Cellular fibroids produce a bright signal, indicating high vascularity and reliance on arterial flow. By contrast, hyaline fibroids are dark, so attempting to starve them fails. Once the cellular makeup proves the tumor vulnerable, its topographic location determines the final strike trajectory. This cross-section map shows a success hierarchy based on tissue depth. Submucosal fibroids on the innermost layer are ideal targets. Intramural tumors are acceptable, but serosal fibroids routinely fail. Cervical fibroids are immune because they draw from an independent blood supply. There is a strict physical cutoff for endovascular treatment. Intracavitary fibroids, smaller than 3 centimeters, are routed away from embolization and sent to a gynecologist for direct hysteroscopic resection. For the remaining viable targets, an operator navigates a microscopic catheter deep into the uterine artery, advancing until they reach the highly tortuous, corkscrew-shaped helicene branches directly feeding the mass. The operator must block both the left and right uterine arteries simultaneously. If only one side is occluded, the tumor will simply recruit a collateral blood supply from the open side to survive. The actual ammunition consists of microscopic particles measuring between 500 and 900 microns, injected directly into the flow to permanently clog the precapillary vessels. A successful bilateral infarction will cause massive cellular death, shrinking the total volume of the mass by up to 60%. UAE is a highly calculated mechanical strike. It relies entirely on matching a specific physical weapon to the tumor's exact coordinate location and its cellular vascularity. Navigating the internal reproductive lumens requires abandoning the strategy of occlusion to focus entirely on mapping and unblocking structural pathways. We hunt for physical blockages causing female infertility using a hysterosalpingogram. A hysterosalpingogram, or HSG, is a diagnostic fluoroscopy procedure where contrast dye is injected to map the internal architecture of the uterus and fallopian tubes. This diagnostic mapping operates on a strict timeline. It must be performed in the proliferative phase, between days 7 and 14 of the cycle, when the endometrium is thinnest to ensure clear visibility. This fluoroscopy image illustrates the mechanical diagnostic test. The operator seals the cervix and forces radiopaque fluid into the cavity under live X-ray to track exactly where the fluid successfully flows and exactly where it stops. Operators must carefully account for false positives. Trapped air bubbles or temporary muscular spasms in the tubes can mimic the appearance of a permanent physical obstruction. They also monitor for intravasation, which is the abnormal backflow of the injected contrast dye into the venous or lymphatic system. This serves as a primary mechanical indicator that the intrauterine fluid pressure has hit a dangerous dead end. If a proximal tubal blockage is confirmed, diagnosis immediately becomes intervention through fallopian tube recanalization. Operators forcefully drive a hydrophilic microwire, measuring fractions of a millimeter thick, straight through the structural obstruction to mechanically restore the pathway. Where the arterial approach succeeds by starving a pathway to induce cellular death, the luminal approach succeeds by wedging open a pathway to foster life. The expansive, low-pressure venous drainage system presents a distinct set of physical challenges. Venous incompetence, the pooling of blood where it shouldn't be, is the shared mechanical flaw driving pelvic congestion syndrome in women and varicoceles in men. These conditions trace back to an asymmetrical design flaw in human vascular anatomy. This fluid dynamics map shows the left gonadal vein draining perpendicularly into the high-pressure left renal vein. Vulnerable to nutcracker syndrome, the renal vein is crushed between the aorta and superior mesenteric artery, generating back pressure and stretching delicate pelvic vessels. We identify pelvic congestion when a patient presents with clinical pain alongside a gonadal vein that has distended past 10 millimeters in diameter. Because this pathology is driven by left-sided anatomical asymmetry, an isolated varicocele appearing strictly on the right side defies the structural rule. It dictates an immediate CT scan to rule out an underlying abdominal cancer obstructing the flow. To fix the incompetence, an operator navigates a catheter deep into the renal vein, injecting contrast to visually confirm the abnormal downward reflux. They execute a staged closure protocol. First, they inject a chemical sclerosant deep into the varices to collapse a furthest, most abnormally stretched vessels. During the retreat sequence, the operator drops titanium coils as the catheter is pulled back, ultimately capping the vessel's origin point with a permanent occlusion plug. Treating complex pelvic pain is an exercise in rerouting traffic. By selectively destroying failed, leaking pipelines, the body's total blood volume is forced into healthier, parallel routes. Pelvic intervention relies on three core paradigms: inducing targeted ischemia in the arteries, mechanically wedging open biological lumens, and forcibly redirecting internal venous pressures. The immediate aftermath of these interventions tests the body's systemic tolerance, particularly in response to the massive cellular death caused by uterine embolization. Patients routinely develop post-embolization syndrome. Post-embolization syndrome is a low-grade fever lasting up to 3 days, representing a normal physiological immune response to tumor necrosis that requires zero medical intervention. We separate that normal inflammatory response from a true systemic complication, such as the sudden release of a massive pulmonary embolism. This occurs when a rapidly shrinking fibroid suddenly uncompresses a major pelvic vein, allowing a trapped blood clot to break loose. Interventional radiology relies on preoperative imaging to map the exact internal coordinates where flow must be terminated and where it must be restored.